All right, good morning, everyone. Thanks for joining us today for another meeting of the Informed Prostate Cancer Support Group. We're going to go ahead and get started here. Thanks again for meeting in person. We're certainly having a great turnout and enjoy having everybody in person so that we can have some good conversations right after the meeting. I'd like to express a special thank you to the Sanford Burnham Prebys Medical Discovery Institute for giving us use of this auditorium. They've been so nice and so supportive of our group. The IPCSG principals are Bill Lewis, our president, who also does our newsletter summary, Jean Van Vliet, the director and treasurer, Steve Pendergast, our secretary and newsletter editor, Bill Manning, our director and videographer, myself, Aaron Lamb, director and facilitator, and John Tassi, our webmaster. And of course, there's you, which well over, I think, 1,000 members by now. And everyone is a volunteer. You can be too. And I'd like to express a special thanks to all of these principals today. I don't point them out and give them the credit that they deserve. Certainly, they all do a lot. Even though you might see me up here during the meetings, they put a lot more effort into this and put a lot more of their time into this on a monthly basis. So please give a round of applause for all those people. And I should have picked a time when Jean would be here in person. Yeah.
Crank up the microphone a little bit.
Sure.
Thank you.
Is this a little bit better? Yeah. Yeah.
Jean had a family.
Yeah, Jean couldn't make it today, and Bill Lewis, of course, hopefully you all know. Bill Manning's in the back, and John Tassi's remote. And Steve Pendergast is here as well. Yes, they do a wonderful job, so thank you all. For those of you who are new here for the first time today, could you raise your hand? Do we have any new people? Excellent, excellent. This is the newcomer packet. Hopefully each of you received one on your way in. Please do fill out and return the cover sheet, either to me here at the podium or to Bill Lewis before you leave today. And we'll be sure to get in contact with you to ensure that you get moving forward in the information that you need. It also contains some articles and booklets. You'll end up, as I said, getting a call from either Bill or Jean to discuss your personal situation. We've already seen how many people are here for the first time. How many people have been recently diagnosed, say in the past 1 to 3 months? All right, so new people looking for what to do. How many have had PCA for less than 1 year? Raise your hand. Yeah, so quite a few of you. And 1 to 4 years? Right, about the same number. 5 to 10? Me, yeah. And 11 to 15? Quite a mix, and longer than 15 years. Excellent. So the point of that is especially for you newcomers, to look around and see that, as you saw on the first slide, prostate cancer isn't a sentence, it's just 2 words. You certainly have a long life ahead of you, and a lot of people here have been focused on treating their prostate cancer for a long time. And those people have a lot of experience. So please do go up to them and see what information they might be able to share. How many people are on active surveillance? All right, a few of you. How many have had surgery? Quite a few. How many have had radiation? Quite a few. ADT and hormone therapy? Quite a few. Chemotherapy? You as well. New treatments, whether it's focal, immunotherapy, Provenge, which we'll hear about today, Xofigo, Pluvicto. Oh, several more. That's a growing number. And how many people have had recurrence, where their prostate cancer's gone away and come back? Yeah, and that's many times why we're here. How many people are undecided on their future treatment? Yeah, this is an important question, why we're here. So, if, again, looking around the room, you might have seen some people raise their hands. That is a indication of what experience they have, and you might want to approach those people based upon the treatment you might be considering. How did people find this meeting? Did they hear about us first at the UCSD Patient Summit in January? I think most of the, oh, excellent. Was referred by word of mouth by another patient? Yes, that's an excellent way to get members in here. Please do pass around all of our contact information, the website, et cetera, to any new people that you encounter. How many were referred by medical professionals? Can I ask who recommended you here?
Dr. Rose from UCSD.
Excellent, Dr. Rose.
Dr. Munt.
Dr. Munt, and I think I saw one more hand. Dr. Siebert, excellent. Yes, UCSD has certainly been very helpful at bringing more, directing more people to us. How many reached us by way of a Google search? That was actually how I got to it. That's been useful. How many have seen the bumper stickers or the trifold brochures around? I see it. Yeah, excellent. And how many have a spouse that discovered us and dragged you in? Yes, yes. Our spouses are definitely a big supportive element of our treatment. And were there any other ways that, how else did you hear about us? Right, right. We did have that.
Newspaper 10 years ago.
Newspaper?
Newspaper?
Yeah. It was certainly an effective advertisement years ago. Not so much these days, but Oh, that's a great idea. Yeah.
Take the whole stack.
Yeah.
We will provide it.
Yeah. And of course, we are on Instagram as well. As you can see the site link up there. Make sure that you go to IPCSG3. We have a lot more followers than IPCSG. In fact, we were at 80 last month, and we're up to 204. So at this rate of growth, we might be able to run for president in 2080? So let's get that number increased. And this also leads to a lot of people even around the country. You might not think about people outside of San Diego benefiting from us, but our recordings on YouTube get viewed by people, even outside the country. So it's don't feel geographically limited in providing support. Now, our support to you, of course, comes in the way of the website and our YouTube channel. Hopefully, all of you are receiving newsletters by email. Those contain just a wealth of information, as you know, summaries of the prior meetings, some of the latest articles and newspaper publications related to prostate cancer. We have our monthly meetings on the third Saturdays every month, not in December though. And we also have hotlines. Here's Bill and Jean's phone numbers. You can also get those on the website. And they're to help you. I mean, I think we all remember back to the first time we heard that we've been diagnosed with cancer and that fear, that feeling of panic in our mind. And, these are the hotlines to call when you have that feeling of panic and need someone to talk to. They've been gracious at providing so much assistance. And additionally, Sharon's number is up here, and that's especially for women, family, and caregivers who also can be going through stressful times and have questions of their own. So please do utilize those. And we do need volunteers. Bill has been fantastic at signing up new speakers, but we would like to hear from you if there are other speakers out there you'd like us to try to bring in, as well as to share your experience. I think we'll have another roundtable coming up in August, I believe it was. And if you are interested in sharing your experience, please do let Bill know. Now, one thing to remember is our support group is our purpose is that we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals. So any sharing by anyone in the group may not be a substitute for your medical counsel. And we do need your support. We are a 501c3 nonprofit organization. Donations are tax deductible. There's no medical or religious affiliation. Our largest costs are the website, advertising, mailings, etc. And please do make a donation. Yes, we've got the baskets to pass around here today. You can also make a donation online via PayPal on our website. You can also mail us a check at the address you see there. Again, address is available on the website. At our upcoming meeting next month, we're going to have Bernadette Greenwood from Desert Imaging come back and give us an update on laser focal therapy. And this year, she's going to be joined by Dr. Aaron Harmon. Now, for today's meeting, we have two presenters. First, we're actually going to have Teresa Gallagher with Sparrow Search. That's going to be giving us a preview of the tool that they are developing, connecting patients with clinical trials. And after that, we're going to hear from the Provenge group. We're going to have Dr. Jim Hsiang, a radiation oncologist, and Tom McKenzie, a patient who's gone through the Provenge treatment. So, Teresa, let me turn it over to you. Yeah. We're gonna have a hard switch over at about 11:05. So let's try to let all the speakers get through what they want to present, and we'll hold questions to the end, unless there's anything in particular you want to open it up to as you're going along.
I have a few discussion questions, but otherwise, please leave your questions until the end.
All right. And we are all set. There you go.
Okay, who are we and why are we here? Good morning, I'm really happy to be here. I'm Teresa Gallagher, the CEO and co-founder of Sparrow Search, and my partner is also here, David Kriegman, who is the CTO and co-founder of Sparrow Search. So what is Sparrow Search? It's a company, it's an LLC, and it's also an online tool to help individuals with prostate cancer find clinical trials for their unique cancer at their preferred locations. We use artificial intelligence and natural language processing to match patients with clinical trials, and we do the work of connecting the trial site on behalf of the patient. We're developing Sparrow Search for multiple medical conditions, and right now, prostate cancer is the first condition that we're working on. So let me tell you a little bit about who we are. I have a PhD in education, so I have a big interest in educating people and helping with health literacy. My PhD is from Stanford, and I have additional degrees in public health, etc., and clinical trials. I've done research on access to medical care at Yale and UCLA Schools of Medicine, and I was a professor of community health at the University of Illinois at Urbana-Champaign. Also founded a clinical research group. So David has a PhD in electrical engineering from Stanford and is currently working in the finance industry in New York City, leading an AI group in a quantitative investing company. So he is actually leading an AI group at 2 Sigma in Manhattan. David has also been a professor of computer science at UCSD for 20 years. He's also an entrepreneur. He co-founded Taz.com, a virtual try-on site where users can upload photos of themselves and try on different hairstyles and makeup before purchasing. Taz had millions of users per month. David also co-founded KBBT, a computer vision company, which he sold to Dropbox and then worked for 4 years at Dropbox, leading a machine learning team. So we do have expertise. We're here to demonstrate to you our test version of the Sparrow Search tool. I'd like to emphasize that this is a product in development that's not yet been released to the public, and there may be some bugs. However, we wanted to share it with you at this point. It says that it's a beta, but it's actually kind of a pre-beta. So we are interested in learning from you as much as we would like to share with you. So, okay, so I'm curious to know how many of you, if any, have participated in a clinical trial? Awesome. Okay. How many of you have looked around at what clinical trials are available for prostate cancer? Awesome. Okay, and if you don't mind, can anybody share their experience of what it was like to look around for a clinical trial, whether or not you agreed to join one? Yes.
Well, when I got my initial treatment at UCSD, I got participated in a trial that they were running. Then after I'd gone through 2 or 3 more treatments and so forth, I looked around to see, because I knew more about my cancer by then, I looked around to see if there were any relevant clinical trials, and I found some in Germany and Australia, but nothing around here that I could participate in.
And we had another speaker.
I think I perhaps looked at over 100, perhaps a couple of hundred clinical trials. They all appears to be necessary to be at the institution which is conducting the clinical trial. The conditions are set up so that once you've progressed in treatment, you may not be eligible.
Yes, eligibility is what we are about. Okay, has anybody, is there anybody else?
Yeah, I'd just like to say that I went looking and found it very difficult to find them, and the restrictions on them were daunting, okay? And so I'm excited about having somebody like you here.
Thank you. Okay, has anybody used clinicaltrials.gov to search for clinical trials? Okay, somebody who hasn't spoken yet, could you share or anybody, would you like to share, yes, your experience with clinicaltrials.gov?
It seemed like the requirements were that if you weren't responding to your current treatment, you couldn't participate. And I think most people looking at clinical trials are looking for something different, for better results, to come off their current treatment, because I'm on ADT, and the only way I can get onto a clinical study is if I don't respond to it any longer. It's kind of like you have to be in the last stages of the disease until they give you something that's stronger.
Yes, that's true. Anybody else like to volunteer their experience? One more person? Okay, good. So, okay, has anybody used other search tools to look for clinical trials? Prostate Cancer Foundation. Okay, and what was that experience like?
It was the same. I mean, it was the same result. They would give you a study that you could participate in, and like the gentleman over here said, it was limited to you had to go to UCSF or someplace quite a distance, Europe perhaps, so they were restrictive.
Okay, so many restrictions. Okay, so first I'd like to start with clinicaltrials.gov, and let me bring it up here. Okay, we're going to look at the beta, or the new, better clinicaltrials.gov. They've been trying to improve it to make it more user-friendly. Okay, I'm not going to put any geographical restrictions on this search. Okay, so what we can see here is that we have a lot of clinical trials in this website. We have over 5,000, okay? Not all of them are in the US. Let's see how many are in the US. $3,269. That's still pretty daunting. How the heck are you going to get through those trials? So let's try another approach, which is within 25 miles of, let's try, what's the zip code here? Okay. La Jolla, California. Oops, that's Julian. Okay. We are going to type in La Jolla. "223 studies within 25 miles of La Jolla. How the heck are you going to go through all of these studies? You'd have to look at them pretty closely in your mind, determine whether or not you're eligible, or maybe you're not able to do that. So do you contact every one of these sites? Which is a problem for the sites because you may not be eligible and it's pretty difficult for you. So this is where we come in. Let's look at another aspect of these trials, which is what people have talked about. As you know, every clinical trial has eligibility requirements. We're not going to look at this one because it was withdrawn. So let's look at the next one. Okay, let's look at the participation criteria. Eligibility criteria, show more. Look at that. Okay, many trials, there's quite a lot here, maybe 30. Many trials have a lot of eligibility criteria. So let's move on and demonstrate Sparrow Search. Okay, here is Sparrow Search again. This is a pre-beta. And first let's look at the top banner, our home, about clinical trials. We have a lot of blogs there about clinical trials. We have a lot of blogs about prostate cancer. And we are focused really on the lower level of knowledge because we really want to promote access to clinical trials. And many people, unlike you, don't have the really sophisticated level of knowledge. Okay, we're not going to talk about the next two. Okay, signing in, okay, registering. This is free to use, but you do need to register to get the full advantage of it. So registering requires email and password. Okay, I'm already signed in. Okay, let's look at the bottom screen. Okay, we have home offices in San Diego and New York. Literally home offices. And we are self-funded. Okay, there are two ways to use Sparrow Search. One is to find trials near me, and the other is to find trials that I may be eligible to join. Okay, and what does that mean? Find trials near me is kind of a straightforward, sort of vanilla search for clinical trials, similar to one that you might do in clinicaltrials.gov or another search tool. Maybe the Prostate Cancer Foundation has one. However, this is our secret sauce, which is finding trials that it may be eligible to join. And so how this works, oops, I forgot something, but that's okay. So how that works is that you complete a clinical questionnaire, and then we match your answers on the clinical questionnaire to the eligibility requirements of particular clinical trials. So let me backtrack a little bit. So the purpose is to find and connect with clinical trials for your unique prostate cancer at your preferred location. There are many, many clinical trials available. They are not all of your classic drug trials, okay, treatment trials. There's a massive array, okay? We use the database of clinicaltrials.gov, everything that's in there. And so there are clinical studies that are not trials. There are basic science studies, there are studies of supplements, and there are prevention studies. So I encourage you to look at it and explore it and think about whether there's another study that you can contribute to, even if you're not looking for treatment. Mm-hmm.
So for a study, you would click find trials when I'm eligible, or how do you find the studies?
You can go, well, we're going to go through it.
Okay.
This is a beta. I'm going to show you every step. Okay, we're actually going to do it. So let's start with find trials near me. Okay, so how many are there? There's prostate cancer trials, there's 1366. Okay, And if you multiply that by how many sites these are located at, I think you have maybe 5,000 data points of potential opportunities to participate in trials. Okay, so let's look at what we have here. First, we have the title of the study. We're going to skip the next column, and then the intervention, which many are drug trials, but again, some could be radiation or something else. Okay, these are ordered by distance from you, the location that you initially entered. And here's the thing, we only selected trials that are currently looking for people. However, you may be confused because you may call a trial that's in clinicaltrials.gov, they may say, sorry, the trial's closed, and that wastes your time. So at the site level, this first study, 7 miles away from here, is active but not recruiting, which means that probably that they aren't looking for any more people, they've filled their enrollment. So you really don't want to bother with that. Okay, another study has been terminated. Maybe it's because they didn't get enough people to sign up for the trial. So I think this provides another level of information to assist you with your search and to help you save time and save the time of the people who work at the site who need to pre-screen everybody who calls them. So let's look more closely at what this offers. Let's look at the closest study. Okay, this is a study of a drug combination for people with locally advanced or metastatic solid tumors. At this site, it's active and not recruiting, but that's okay. It's for informational purposes. It's a drug study, it's treatment, it's phase 1, phase 2. You need to be a minimum of 18 years old, and there's no upper age limit. And it's an interventional study, means that you're going to get something, and you're probably going to be randomized to a placebo or treatment group. However, this one is not randomized, which probably means that it's an open label study and it's early phase, which it is. This is the sponsor of this study. I don't know how to pronounce this, Exelixis, if anybody's familiar with them. Okay, so we have a summary of the trial, a list of the interventions, the drug interventions. We have the eligibility requirements, which I'm not going to get into right now. And let's just pick one of these study resources. So for this one, there are a variety of publications that will help you to understand this trial better. And sometimes there's even websites for the trial. So we're going to skip these other sections. And let's see. Let's go to locations. This trial has a lot of actually there's only one really nearby location, and this is ordered by distance. So there are a lot of opportunities, but if you're up to it, you may need to travel. And sometimes trials do pay for your travel expenses and for you to stay at a hotel, etc. So you want to look into that.
It says trial number 51. Where did it say that on the previous search? How do you know you're looking at the one left?
Yes.
It says clinical site number 51.
Mm-hmm.
Where did it say that on the previous screen so that you know you're looking at the
It doesn't. The previous screen is just an overview of the study, which provides basic information. I clicked on locations, which provides the locations. And this company is pretty confidential. They're not going to tell you, they're going to numbering their sites. They're not going to tell you this is at UCSD, etc. And they're not going to give you any contact information for this site. So they're kind of secretive. They're not also giving you the name of the investigator at the site, which many other studies do. But that's okay. We can still contact them. We will go to the overview page. And there's a spot here where you can contact this study. Now, this will connect you with the central site for the study, overseeing all the different clinical sites. But that's okay. That's good enough. So let's contact the study. So this information is not correct in here. But your name would go on there, your phone number, your email address, and the study ID from clinicaltrials.gov for this study. And I don't want to contact this study because things might happen that we don't want to happen. So we are contacting the study for you. You don't have to worry about playing phone tag with them and them not answering and leaving voicemails, etc., which is what they do. Or sometimes I've tested sites. Sometimes they don't even contact you after you contact them. So those are the locations. That's about that study. Let's look at another one. We are only interested in studies 20 miles from here. Okay. Let me go across these. These are called filters, okay? A study is probably looking for people. We only selected studies that are looking for people overall. The primary purpose of the study could be treatment, which many people may be interested, but there's really a variety, okay? You can participate in a prevention study. You can participate in a basic science study, etc. Okay, so we're gonna close that. The trial phase, you may not want to participate in an early phase trial, but you know, if you're really interested in the drug, you might want to consider that. More filters. Okay, we're going to skip the eligibility one. We're going to go to study type, which tells you whether or not it's an interventional or observational study. Let me give you an example of an observational study. You don't really get an intervention, but they just kind of study what's happening with you. For example, an example of an observational study could be, okay, men with recently diagnosed prostate cancer, what is their anxiety level? What are they feeling? Okay, let's look at one more study. This one is recruiting, so that's good, the second one. The characteristics of the study are across the top. You have the study purpose, inclusion, exclusion criteria. And this one, let's see if there's any study resources. No. Okay, we're interested in where the study is being offered. Here are the locations, okay? This company, let's see who's doing this study. National Cancer Institute. They're a lot more open. So they're telling you the actual clinic where the study is being conducted, sorted by distance from you. They tell you who the principal investigator is at the site, and they give you the contact information at the site. So let's try this out. Okay, we have to be careful here. I don't want to click this to contact study because this is real information here, okay? The email address of the study, the name of the person, their phone number, and the study ID. So let's not do that. Okay. So that was search for a trial near me. Actually, there may be another function here. Okay, you can also compare studies, okay? Let's say it's really hard to differentiate between these studies. Let's get an outline of how they're different. So let's check this one, let's check this one, and let's check this one. And let's compare them. Okay, we have a bug, which is some studies, the two on the right are repeated, but that's okay. We can compare the first two. You have a summary of this study. We want to shorten that. The nearest clinical site, which is, again, the secretive company, UCSD, the miles. The status, you don't want to bother with this because it's not recruiting right now. They're both treatment studies, and they offer different drugs. Are you interested in any of those drugs? You probably might want to consult your physician or do a little bit more research of your own to learn about those drugs. There are different phases, okay? Study sponsor. The second one is being sponsored by Dana-Farber. And no age, no upper age limits. Nice. Okay, so let's try it the other way. Okay, this is our secret sauce. Finding trials that I may be eligible for, okay? So you need to answer the clinical questionnaire in order to find trials that you're eligible for. We tried to make the questionnaire very patient-friendly, where you're not going to have to consult your doctor or detail medical records in order to answer it. So our goal is, again, to bring in as many people as we can to clinical trials and help them by providing them with information and improving their health literacy. It looks like this one is already filled in with somebody else's information, so we are going to reset it so that we can put in our own. Okay, what type of prostate? Now I have a case here that I'm going to use, a particular patient profile. Okay, what type of prostate cancer do you have? Adenocarcinoma. Here we give additional information if people need it, just to answer the question, saying that this is the most common type of prostate cancer, the others are rare. What is your Gleason score? Okay, in my test case, it's 8. We explain what a Gleason score is, again, to help people. And we tell them the range, which is 2 to 10. We explain that the difference between the Gleason score and the Gleason grade, because they have different ranges. If you have a 10, that's a Gleason score. Okay, what was your most recent PSA score? 8. What was your most recent testosterone level? 80. This may not be a realistic case, but, you know, it's a demonstration purposes. Okay, has your prostate cancer spread? Okay, we inform people about metastasis, and it has spread. Where is it spread to? Okay, locally and to my bones. We explained that bone metastasis is the most common location for metastasis, and other locations are more rare, like other organs. People may not need to look at this, but just in case, it's to help them. Okay? Have you had radiation therapy? Yes. What type of radiation did you have? Have you ever had surgery? Yes, for your prostate cancer. What surgeries have you had? Okay, we have a bug here, so we can't answer a lot of questions. We're just going to skip it. Otherwise, the system might get hung up. Need to fix that. Okay, have you had cryotherapy, which is a focal therapy, as I'm sure you know? We explain it. Because we don't want people to say, I don't know, or just to skip the question. We really want to help them understand what it is so they can make the right answer. So no. Have you had HIFU? No. Have you had an orchiectomy? No. So far we're doing somewhat good. Okay. Have you taken hormones? Yes. Have you taken any of these medicines for prostate cancer? Okay, we don't want to ask people, have you taken androgen deprivation therapy? Because they might not know, and we're trying to reach the common man, people that don't necessarily have an advanced degree or maybe a college degree, but that's our goal. Okay, taking leuprolide. Is your cancer hormone resistant? Yes. Have you had chemotherapy? No. Have you ever taken any of these medicines? These are what I call, I hope I'm okay on time. These are what I call the forbidden medicines, okay? If you've taken any of these medicines, you're often excluded from trials. And let me explain why. Okay, this person has taken enzalutamide. So as you may know, many of the new studies are testing combinations of drugs. And enzalutamide might be the base drug that they're testing in combination with something else. So you may be excluded from those trials if you've taken enzalutamide. I explain these medicines. Did you have a heart attack in the last 6 months? I did. Uh-oh. As you know, we prefer healthy people to participate in clinical trials, and if there's something wrong with you, there's a good chance you might be excluded. So, we'll see. Did you have a stroke in the last 6 months? Fortunately, no. It includes TIA, which is a temporary, well, I don't need to explain it. Okay. Do you have very high blood pressure now? Uh-oh, I do. Okay. And here we're talking about, let's see, greater than systolic, greater than 160, or diastolic, greater than 100. So that's pretty high. Very high. Okay, any of these heart conditions? No. Do you have a pacemaker? No. Do you ever have HIV or AIDS? No. And you could be excluded if you have had it when you were 20 years old. You could be excluded. How active are you? Okay, as I've stated, and I'm sure you understand, trials want healthy people. Okay? And often eligibility requirements say, okay, aside from your cancer, all your organ systems working well, and some of them even say, what are your measures? What's your hemoglobin measure? What's your, all your measurements, okay, physiological measurements. This is, and I really didn't want to ask people that, but this is actually a really good measure. This is called the ECOG, and it's a scale that's very often used in clinical trials to include or exclude people. Okay, it ranges from 0, 1, 2, 3, 4, based on how functional you are. Okay, first one, you're fully active, so that's a 0. You can do everything that you did before getting sick. The second one, a 1. I can walk. I can probably sit in my computer all day and work. I can make myself dinner, and I can clean up the kitchen afterwards. Okay. Often the cutoff is 0 to 1. You need to be in a 0 or 1 in order to participate. If you're lower than that, chances decrease. Okay? But some studies take people that are down to 0, 1, 2 to 2. Okay? Now, an example of this status would be my 89-year-old father having his 89th birthday. And what about him? He's spinal stenosis and he has heart failure. He's had multiple bypasses. Still doing well. Okay? He can walk with his walker. He can take a shower, but he can't work. Okay? He's up and about, but he cannot cook himself meals. My mother brings his meals to him on her walker. And he can't empty the dishwasher, and he cannot make his nephew a shake in the morning. So he's a 2. Whoops, forgot to put the number in. How long do you think you have to live? Okay, we need to rewrite this question. But you're going to be 100. How do you know? Okay, so we need to rephrase this. Why is this here? Because many studies require a minimum life expectancy in order to participate, okay? It could be 6 months, it could be 12 months, it could be 18 months, okay? Those are usually the cutoff points. So we would rewrite the question to focus on that, okay? This is in months, so I'm going to live 20 years, hopefully longer. Yeah, 240 months, 10 months. Okay, thank you for pointing out my potential mistakes, okay? We are in La Jolla, San Diego. I really only want studies within 20 miles of me. And this is where I got really anxious. It does work. But I'm really anxious. It takes a while.
Shows you how much work is going on behind.
Yeah. Oh, yeah, I forgot to mention that our web development company is BitCaught and advertising for them, and they're in Rancho Bernardo. And we have conceptualized and designed all of this, but they've done the work. Okay. So now we are going to look at the secret sauce, which is whether or not you're eligible for particular trials. And again, these are ordered by distance from La Jolla, and you can see that you are not eligible for most studies, at least on this page. Ignore the fact that there are duplicates. We need to fix that bug. But still, the fact is that you're probably not eligible for most studies, at least on this page, and it's also true on the next page. Why are you not eligible? Okay, you don't meet the eligibility criteria, at least the ones that we measured in the questionnaire. You either don't meet all of the inclusion criteria, or you have something that's kicking you out. If you had a heart attack, okay, if you're 89 years old and can't empty the dishwasher. Okay, so let's look more closely. So these are the pies, which the first one, the kind of greenish mustard color one, is that you're partially eligible for this trial. The red is you're not eligible. Okay. Oops, I saved this one before with my prior marks, so I'm gonna unsave it. Okay, first study, let's take a look at it. I'm partially eligible for this. What does that mean? Okay, again, it's a drug intervention study. It's a combination study. Inclusion criteria, this one's pretty straightforward, okay? That your ECOG performance status is 0 or 1. If you can't empty the dishwasher, probably not eligible. Okay, locations. Okay, this is Exelixis again. Not very forthcoming. Okay, let's see. Whoopsies. Let's look at the second study. Is this site really doing what it's supposed to be doing? Okay. Another drug combination study for people with advanced prostate cancer with bone metastasis. So we're good that way because we have advanced prostate cancer with bone metastasis. So yay. Okay. Inclusion criteria. Must have adenocarcinoma. Yes, we do. Participants must have castrate levels of serum testosterone less than 50. Uh-oh. We don't meet that criteria. Ours is 80. Next, must be maintained on LHRH agonist. Okay, so we have, at least in the past, taken hormone therapy. Okay, ECOG score less than or equal to 1. We're good. HIV one, we're going to skip. It's a bug. Okay, exclusion criteria. Okay, we have had external radiography. So bye-bye to this trial. The other one, consistent with small cell carcinoma, I don't know if this is a bug or not, but we don't have small cell carcinoma. Okay. We could also compare those studies, but we're not going to do that. So what have we accomplished, okay? What have we done for you? We've eliminated a lot of studies that you really shouldn't bother with, okay? In fact, this first one that you may be eligible for, they are no longer recruiting, okay? So forget that one. We've saved you a lot of time, and we saved the sites a lot of time and expense screening people, okay? We would consider this a pre-screen. Let's see what else, okay? So we've saved you time. I didn't save any trials, but they would be in there if I did. And you can see that you can email the trials that you've selected to your doctor, okay? Rather than bringing in 20 trials to them that you're curious about, you can bring in a few, okay? You can download it and you can print it. Okay, and the last feature, which is clinical history, okay, the questionnaire. Maybe your situation has changed. You're getting better, or things have turned for the worse, or just your numbers have changed. And so you can reset. I'm not going to do it because something bad might happen right now. And so you can edit, okay, each of these, and it'll recalculate your eligibility. Okay, that's it. We obviously have ambitions to go way beyond this. David has a full-time job. Sparrow Search is his hobby. We need more people, and we are looking for seed money, and we just want to move more quickly and go into other conditions.
I'm curious about these people that set up these clinical trials. How do they go about recruiting patients now? And the other question I had was, you mentioned in your patient information about the Gleason score as one number, and it's my interpretation that it's normally treated as two numbers, like 3-4 is different than 4-3.
You're right. I didn't break them down because the inclusion and exclusion criteria don't always break them down into the two numbers. So that's why I use the additive.
And
number.
that's the latest Gleason they want, huh?
Mm-hmm.
So like I had pre-operation operative Gleason from pathology for my biopsy, and then after they found out I was an 8.
Yes, it's the most recent number.
Right.
Okay,
Thank you.
how do trials recruit people? Okay. Oh, yes.
Thank you. The question I have is, you've invested a lot of money to develop this search engine. If I want to use it, do I have to pay for it, or is this open to anybody to use, and you're being paid by the providers, or you've gotten a federal grant to develop the engine?
Yes. Right now we are self-funded, but we cannot continue that way. And our business model is indeed to get money from the pharma companies for referring pre-qualified patients to them. Of course, it's free. That's our goal, which is to provide access. Oh, and another way, okay, how do sites find people for clinical trials? Well, I live in New York. There's ads in the subway for clinical trials. They use Facebook ads a lot, okay? But as you know, if you're a patient looking for a trial, that's catch as catch can, okay? You can't search Facebook and find a trial. Another source, which somebody alluded to earlier, is that if you're a patient at UCSD and your doctor happens to be running a trial, well, they're going to tell you about that trial and see if you're eligible and, you know, assess your interest in it. But if you're at Scripps, they're not going to know about trials happening at UCSD, okay? So we're here to help.
Are you planning to go to other diseases, or what's the? You said you were going to trying to go bigger or something. What do you mean?
Yes, to be perfectly honest, we chose prostate cancer because my husband has, you know, an extensive family history of prostate cancer, so it was a great interest to us. But our goal is to do all medical conditions, and but we need to work out our methodology a little bit more, and I'm very curious to do Alzheimer's next, because as you might know, people with Alzheimer's are really desperate for treatment and to want to know what's out there. And I'm actually interested in a prevention study for Alzheimer's, and they're out there as well. Yes?
I'm curious why they want the Gleason score. My Gleason was 10 years ago, and I've had a prostate, so I'm naive on what you're talking about. I think it would be a PSA score for me.
Mm-hmm.
How is the Gleason relevant when my prostate was removed 10 years ago? This might be off, but I'm just curious.
That's a good point. Yeah. So we have to look at the timing of that. So it's a good point. But it would be your most recent. What's that?
With the prostate, PSA numbers. My concern is the increase in the PSA number,
And that might be something you want to consider. I don't know if they're using that in criteria for getting in a clinical trial also. Is the growth rate of the PSA went from undetectable and it's been climbing at a pretty steep rate in the last 4 years.
For that, it's the most recent PSA, and hopefully, you know what that is. I think it's, yeah, it's pretty easy to get. Gleason is a little bit more complicated in terms of the timing.
All right, we have about 10 more minutes for questions.
I just wanted to comment on the question about the Gleason score. Even though your prostate's been removed, there's cells floating around in your body, and these study people want to know if you ever had Gleason 8 or 9 cancer, that means that there's a higher likelihood that some of those cells will activate and move forward. So they want to know that. But I think you wanted to be sure that they knew we're looking at the PSA, and that was on her list. But I think it's a good point that the PSA velocity, the change in the PSA, it could also be important, but they don't design the clinical trial, so they're doing the best they can with what these people ask.
Yeah, it wasn't high. It's not more than likely it's certain.
What's the URL? In other words, how could we use this if we wanted to try and use it?
You can't use it right now because it's just not ready. So probably in about 6 weeks, we have business cards out front. Our website is sparrowsearch.health. Okay, and you can see what's out there now, but it's not the tool.
And we'll make sure that once it does go live, we'll probably put the link in the email, or in the newsletter, I mean, and send out an email.
That'd be awesome. Thank you. And just to say, I'm really pleased to be here. And you're a really important group, and the organization is incredibly organized, so I'm very impressed.
I just had a question about expanded or extended trials. I believe that means that they've run a phase 3, but they've not stopped accepting participants. Is that the correct understanding?
Yes, and there is an option here. We do have a filter for expanded access, participation in a study. So you can look for those.
One of your disqualifications was a heart attack, and then there was a quick list of other heart problems, and I wasn't able to see that list. What were they?
Yeah, I went through that pretty quickly. One example is angina, but it's okay if you have angina, but if you have unstable angina, you're out.
What about atrial fibrillation?
I think that's on there too. I'd have to bring it up, but it has to be unstable. Yeah. I mean, yeah, it's stable. Yeah.
So I imagine that a lot of the criteria that you have pulled out and pulled into the questionnaire are essentially line items for the different trials. So, if it doesn't appear there, then it probably isn't relevant and it probably doesn't kick you out necessarily, although there could be some things that perhaps are. Are you doing a little bit of extra filtering beyond what they have in black and white for the trial requirements, knowing that certain types of patients would eventually get rejected anyway?
Sorry, I had one of those moments. Okay, so in terms of the criteria, the eligibility criteria that we chose for the questionnaire, we chose criteria that were very common across studies and one that people can readily answer without, looking up their records or asking their doctor. So we may expand the questionnaire to look at a couple more exclusion criteria, but and inclusion criteria, but we're probably not gonna be 100% accurate unless it's a very simple study, for example, a weight loss study where you just have to have prostate cancer in order to join.
I was wondering,
today is these large language models like ChatGPT and Bard on Google. Have you looked at maybe rolling in a large language model into your front end?
That's a great idea. We definitely want to expand because AI, machine learning, is our core expertise. So thank you for the suggestion. I have used ChatGPT for this, for the explanations that I had on the right side of the screen. It just saves you a lot of time. So.
Any other questions?
All right, sorry about that. Can you do a search for a specific medication, clinical trial? Because you can do that on clinicalstudies.gov. You can punch in whatever it might be and it comes up.
Yeah, that's very important. You may be looking for a particular drug study. And or an immunotherapy, for example, you may be looking for, is it Provenge studies? We don't have search capacity right now, but of course we need to have that ability. Yeah, we are self-funded, so as we move into our next stage, we need more
It's just a suggestion. A lot of us are on newsletters that we get, like from the Prostate Cancer Foundation. And if there's a new introduction or new breakthrough, it'll be on a newsletter. And sometimes they say clinical studies available, and if we could put the drug name, it would be much easier to search.
Yes, yes. But if you search on clinicaltrials.gov, obviously you're not going to be able to determine whether or not you're eligible for that study. But you can, but it's not at this level. What criteria you're thinking of? I mean, they're really basic ones like age, you know.
No, it tells you specifically. If you're responding to a particular drug, you are not eligible for this study. It tells you very clearly.
You mean if you go on the trial detail and look at the particular? Yes, yes. But there may be quite a lot, and you can do that, I'm sure. But again, many people cannot, don't have the health literacy to do that. So, but yes, we are going to have that search capacity. It's crucial.
Do physicians routinely recommend clinical studies for their patients? And are there any costs ever involved with the clinical studies for the patient?
Yes. And there's, well, first of all, there's potential benefits, but there are potential risks. It could be an inconvenience, and there can be costs incurred, okay? The company pays for the drug. Your health insurance may pay for all the screening and testing that you need, but not everything is going to be covered by your insurance. So you may have some out-of-pocket costs, as well as if you're traveling, you know, all those extra costs. But we can say, oh yeah, there's no cost, but look more carefully.
All right, in looking at the clock, I'd like to switch over to the other presenters. If you have more questions, I'm sure that both Teresa and David will be around during the lunch afterwards, and we can have them answer more questions then.
Thank you.
So just give us a minute to switch over to the other speaker and the other laptop. One thing I should point out is our restrooms are out the door in the back of the auditorium, down the hall to the left, in case anybody needs to use them. But next we're going to have Dr. Jim Hsiang, who's a radiation oncologist at the Corpus Christi Urology Group and Cancer Center. He has studied at UCLA, UC Davis, and received his residency training at Southern California Permanente Medical Group. So give us one moment to get this set up.
All right, great. Well, thank you for having me. I'm Dr. Jim Hsiang, and thanks for introducing me. So it's great to be in La Jolla, Southern California. I've been out several years now since my training days, been in Texas actually. So we had a lot of lightning recently that caused a little delay to get here. But you guys have beautiful weather, of course, here, always. But I'm a radiation oncologist by training, which is a little bit unique. I know a lot of you probably have seen urologists. So I do work with a large urology group there, and it's called Corpus Christi Urology Group and Cancer Center, so I'm on the and part. But I do head the Advanced Prostate Cancer Clinic there, and so we do treat a lot of patients with Dendrion's Provenge that we're going to talk about today. And so without further ado, we want to talk about empowering you to take charge of your treatment with Provenge, or some call it Sapilocil T, some call it just SIP-T for short. As you know, this is a promotional program sponsored, paid for by Dendrion. Information will be consistent with the FDA guidelines and approval for its use. So on the agenda, we want to talk about living with prostate cancer, the FDA approval itself for the immunotherapy. We'll cover what metastatic castrate-resistant prostate cancer means, the acronym there, shortly. Provenge process, and the real question is it right for you? Empowering you to take action, and a great personal inspirational message from Tom, our patient ambassador, to follow me, and then questions and answers. So how common is prostate cancer? Is 1 in 8 men. The analogy I always throw out there is when we think of breast cancer, it's very similar actually, 1 in 8, some say 1 in 9, depending on what you read. But it's just as common as breast cancer is the point. So in addition to thinking pink, we should think light blue or sky blue, the color of the ribbon for prostate cancer. So it's 1 in 8 in a lifetime though. The average age of diagnosis is 66, about almost 270,000 new cases a year, the incidence, and that's new cases, keep in mind. So that's a good number. Greater than 3 million actually have been diagnosed at some point and are still alive today, and that's good news. There's an increased risk, and we'll get into a little more detail later, but increased risk for African American patients. It's interesting and unfortunate, actually, when you look at those statistics. It's all greater than other races, especially compared to Caucasians. We'll have a trial shortly to show you that. But 1.7 times greater risk of having prostate cancer, 5 times more than risk of diagnosis at an earlier age, greater risk of advanced disease, higher Gleason score. That tells you how aggressive the cells are under a microscope. Greater chance of death, 2.4 times the rate of death. This is a good slide to show you in general terms. We start with a localized cancer on the left-hand side, and then you usually have radiation or surgery, really the only two curative options out there. And then sometimes PSA unfortunately starts to rise. You can have recurrence. We start doing imaging, and physicians usually start with androgen deprivation therapy, hormonal therapy. And then even despite that, sometimes you can have progression, and that's when you get into this advanced prostate cancer stage. And what are the chances, by the way, of prostate cancer coming back after your initial surgery or radiation? Certainly it's not so high, luckily, but a lot of folks are surprised when I tell them it's about a fourth, actually, which is still, we wish it would even lower, but a fourth of men can recur, and oftentimes without symptoms. So it's important to continue to have PSA routine monitoring. I always tell patients, they always ask me, I've already, the urologist took my gland out. Why do I need to come back? And I tell them there are actually recurrences. The way it works is sort of over time. If you picture a graph with time on the x-axis and recurrence on a y, and it goes down, I should point out this way, it goes down over time, but it's never really technically zero. It goes very low, but there can be late recurrences, is the point. So imaging as well is very important. We'll get into that. And certainly tell your doctor if anything changes out of the ordinary. So what are some of the monitoring tools we have? As I mentioned, PSA. Most of the folks do it every 3 to 6 months. Certainly if it's rising, as a gentleman mentioned earlier, we look at the rate of rise. If it's rising a little faster, we would follow a little closer. Testosterone we also measure similarly. Imaging can be done every 12 months. There's various options out there, bone scans, MRIs, CT, PET CTs. And so also important to know, imaging is very important these days because the PSA could stay low or minimally rise or may not even rise much, but radiologists may see a progression on the imaging, and so that's important to find. So in general, living with prostate cancer, there's a few things that Tom will get into as well, but in general, I always say these are bullet points are really things that we like to do anyways, right? We want to stay healthy in general, managing our stress, stay close to our social network, our loved ones, practice healthy sleeping, limit your alcohol or smoking, maintain a good weight. Ultimately, the goal is survival, right? To live longer. So when considering treatments, it depends on many factors, as we'll get into, but basically your physician, it's a sort of personal decision between you and your physician, and it will depend on other factors like your age as well, other conditions. But again, early detection is key, whether it's for detection of diagnosis or even later progression especially. So this is the only FDA-approved immunotherapy for metastatic castration-resistant prostate cancer, and it's made from your own cells. I think there's slides coming up, but maybe since I've already mentioned that twice, let's just cover that real quick. So metastatic, as we've talked about, or earlier speaker has mentioned, loves to go to bones, lymph nodes, and so bones are the most common, but lymph nodes are very common as well, and they're part of our immune system, and that's why Provenge works in a way that it's going to allow your own immune system to fight the cancer cells. And so the metastatic part is what it's helping with, well, overall, but you have to be metastatic to qualify. And the C part, called castration resistance, a few slides later will probably show that the PSA is going to be rising despite a low testosterone level. So means basically, in a nutshell, the hormonal therapy is sort of wearing off, so we need to do something different. And so immune system in general, all of us have immune systems, and it helps to fight against disease, illnesses. And so your own immune system can detect these cancer cells, and the better we can sort of arm them to identify, kind of like identifying a trial for you, this is letting your immune system identify the cancer cells and fighting it. This is sort of a busy slide, but it's a nice one to see where there's various mechanisms for cancer progression, or pathogenesis they call it. It can avoid immune destruction altogether, sustain proliferative signaling, resist cell death, evade growth suppressors, and you see a few other points there. So just as the cancer fights us with various sort of mechanisms or pathways, luckily our immune system does the same thing. So another kind of busy slide, but it's good to point out a few things. Antigens are sort of a protein, and so there's an antigen marker, part of the immune system, like an antigen, including antigen-presenting cells. That's sort of like a matchmaker, if you will, that helps to allow your part of the immune system called T cells to find the cancer cells and sort of tracks it and brings it to that site. There are antibodies from B cells that also Y-shaped protein. They also help to fight and grab onto the cancer cells. Killer T cells do the actual killing. It's called killer T cells, and then some immune checkpoint regulation as well. This is a great slide to show that immunocompromised individuals can have greater risk of having cancer. And as you see, it's a little smaller font, but prostate cancer is second to the last down there. Now, so it's not the greatest risk. So the highest risk is kidney cancer. So those with lower immune systems or immunocompromised patients have a higher risk of kidney cancer. But the point is, prostate cancer, even though it's lower down the list, that's still twofold risk. So certainly I don't want twofold chance of having cancer. So keeping your immune system up and healthy is very important. So in terms of immune cells being there, immune cells fighting the tumors, this is actually directly correlated to overall survival. So if you look on this nice, what's called a Kaplan-Meier curve, basically overall survival, or OS, on the y-axis there. On the x-axis is over time in months. We see the sort of brown color curve on top, this aqua greenish curve on the bottom. And so basically, you want the higher survival, of course. You want to be on that top curve. And so if you go to the right-hand side, I forgot I had a pointer. If you had a right-hand side, we see actual T cells infiltrating the tumor cells, sort of these brown, reddish spots. So that's what you want. You want to see a whole bunch of T cells right in the cells, and that's where you're going to have a better outcome. Whereas this picture, Part B, you have a lot less intratumoral T cells detected. So your immune system plays a major role in fighting the cancer cells directly, and it directly correlates to a better outcome. This is a nice sort of what I call a legal picture, right? A balance of escape versus elimination. So basically, the cancer cells have 3 E's. They call it a sort of a dynamic process. There's escape, of course, if the cancer overwhelms your immune system. We don't want that. Elimination, where we really get rid of it, and hopefully we all can eradicate, sort of go for a cure, a long-term cure. However, one thing to keep in mind, I always tell patients, even especially in an advanced or progression sort of type of state of disease, equilibrium is very important, and to me that's a success already. If you're able to keep it in check and keep it from getting any worse and don't have progression over time, that's a success already. And what we're finding out with all these therapies over time, it can become more almost like a chronic disease, if you will. Some folks may not agree with that, but that's what we've been seeing in the last few years with all the therapies out there. All right, so in summary, as we talked about, immune suppression is a bad thing. It can increase cancer risk, but we can fight that, our immune system can fight that with T cells, and that will correlate with better outcomes directly. Another general slide, again, mentioning immunotherapy with relation to cancer. And so just as we've shown how important the immune system is inherently, so the idea of a therapy like Provenge is it's a very customized immune therapy to let your own immune cells sort of get revved up and boost them to be able to fight the cancer cells. And here we go. So it's immune therapy, and studies have shown that in certain men, as we mentioned, metastatic patients and castrate patients, so you have to have both at this time to qualify, they will live longer based on their trials and based on lots of data from the community we'll see shortly. Since its approval, FDA approval in 2010, so it's been around for some time, as you see, nearly 40,000 men have received this treatment. The formal indication is, again, used for advanced cases, metastatic and castrate-resistant. And again, it's a cellular immunotherapy customized based on your own immune cells. Kind of a busy slide. It actually repeats a little bit later. I'll just mention a few things. The side effects we'll mention shortly, as well as the way they give it. So I'm going to go forward, and I'll come back to some of those for sure. So now keep in mind, Provenge works very differently from other therapies. And very importantly, it does not lower your PSA. So I'm going to say it one more time. Provenge does not lower your PSA. And that's mind-boggling, even for urologists. And I try to explain that to them too sometimes. So we've been training patients as soon as you get diagnosed, or even before you get diagnosed. From day one, we talk about the PSA, that lab value. That's all we dream about. It's in our, right? It's or nightmare, I should say, PSAs. So for the first time, we ask you to sort of reprogram yourself. Not that it's not important. We still look at PSA. But remember, progression can occur even without much or any PSA rise. And so when you have therapy through the immune mechanism, it's killing the cells, for the T cells are killing the cancer cells, but that's not correlated with a drop in PSA. So it doesn't mean it's not working if your PSA doesn't go down. So that's a very important point. However, more importantly, though, it improves your overall survival, and that's the endpoint we want. So this is their sort of hallmark, landmark study called IMPACT trial. It's a controlled randomized phase 3 trial, 512 men with mCRPC. And as you see, the top blue, darker horizontal bar graph, men lived for almost 26 months versus about 22 months for patients who did not have Provenge. So 4.1 months longer. Now keep in mind, this is a very strict, randomized trial, very strict criteria for enrollment. But 4.1 months, when it first came out, the question was, or a lot of folks said, oh, is that a lot? Is that a little? Well, we're going to show you a little interesting further evaluation of the same trial, keep in mind. This is the same trial, but looking at sort of a subgroup analysis. And it's very informative because what we found, or not we, what Dendrion found was that patients who were treated earlier with a lower PSA, sorry, on this side, did better. So if you go from reverse, patients who had, if you could see that low, small font here, if you had PSA greater than 134, can you imagine having these days PSA greater than 134? Luckily, it's pretty rare. So we jump in a lot earlier than that these days. So, but back in, remember this trial was approved in 2010. So many years ago, if you had PSA greater than 134, had Provenge, you had a benefit still. It's not like you didn't have it. You do have a benefit. You live 2.8 months longer. As you go from right to left in this sort of quartile fashion, four subgroups, you see it increasing. In fact, this is the group we're basically in now, today's time. So PSA, if you had a less than 22, you had 13 months overall improvement in survival. And that's certainly greater than that 4.1 months number. And so what we learned is that if we treat patients earlier, you can have a more than a year increase in survival. So that was statistically significant. And similarly, if you look at real-world data, this is more recent trials, including up to 2,000 men, so a lot bigger sort of study. Not really a trial, but I guess study is a better term. So it's not a randomized. But as you see, the overall survival in a similar fashion is that this time, many years later, we treated PSA earlier. But even then, we had certain patients or physicians who waited until PSA was greater than 46 or 15 to 46. 5.27 to 15, and the most important one to remember is we want to treat patients in this category, less than 5.27. So we're looking earlier and earlier for patients who have PSA starts rising to start Provenge earlier because they have the greatest benefit, almost 48 months overall survival. That's 4 years. So there's analysis based on real-world study. Again, it's not a randomized trial, but Medicare beneficiaries, again, even greater number of patients, 6,000 patients treated with Provenge. And they were looking at it versus what's called androgen receptor signaling pathway inhibitors, a lot of these newer oral agents that you might have seen earlier on the other talk. But the point is we see the bar graph on the left blue bar, much greater overall survival, 35.2 months, versus 20.7 months. And in this case, it's 14.5 months difference. As I was mentioning earlier, in the PROCEED registry, it's called the sub-analysis of that study, they actually had a decent amount of enrollment for African-American patients. So going back to the Sparrow engine, it's very important to emphasize, thank you, by the way, for going over clinical trials. It's very important to try to find the right one for you, to enroll in it, and to really get through the clinical trial. But in this case, when they looked at it, they realized early studies, they noticed some benefit for African-American patients, and lo and behold, they looked at it and said, wow, for PSA-matched African-American men versus Caucasian men, they actually did so much better in outcome. In fact, if you look at sort of two groups they looked at, less than about PSA 30 versus greater than PSA 30. So in both cases, African-American men did better, and both groups did well and had a benefit, or African-American men did better than Caucasian men in both groups, but the greatest benefit is sitting here. So we get back to this safety information. So let me just mention a few things. So most of the side effects, I think another slide does show, but most of the side effects are related to, it's about an hour-long infusion. So when they put your immune cells back into your system, it takes a little time, but when that happens, you can get a little shivers, a little cold. They call rigors. So we have a nice blanket for our patients there. And most patients do very well and are self-limiting within a day or two, sort of mild to moderate effects. Sometimes headache, you can get fatigue, fever, a few other ones listed on there in very fine print. Nausea, joint ache, headaches. More severe cases can occur down here if you look. Certainly, you want to be aware, let your physician know if you have trouble breathing. You can have signs of lung problems, heart attacks, strokes. Extraordinarily rare, relatively rare, but those are things that can still occur. Um, and the process we will get to right now are coming up. Here we go. So as I mentioned, it's a personalized dose, and so it's manufactured specifically for each patient. So it takes a few days, but in day one, you go to what we call a blood bank center, and it's called leukapheresis. So you're hooked up to these large bore IV, pretty large needles. Your arm's kind of stiff. You have to be out here. So they take blood from one side, and it circulates into a machine, and it goes. The blood actually, most of your blood goes right back to you. But meanwhile, they're taking your white cells away. And by day 2 and 3, they send that off to a manufacturing facility, and so they're exposing it to sort of the antigen of the cancer and revving up your cells. And then when they put it back into you, that 1 hour infusion, day 3 or 4, it's done in an outpatient procedure in our clinic, and that's when they're putting your white cells back in your system. The whole process takes one visit for the leukapheresis, another visit for the actual treatment. You take a break for 2 weeks, you do it again, and then you take another 2 weeks break, do it a third time. So roughly takes about a month to maybe 6 weeks, depending on when you start the day. But 3 total treatments. A few steps, vein assessment. So the blood bank center has to look at your veins, make sure they can get access. There's a certain little measurement they take, make sure you can handle the pressure of the withdrawal. Oh, sorry, I forgot to mention. Every once in a while, we did have a few cases of, when we first got started. Temporary central venous catheter could be used. That's a little more cumbersome and complicated. I try to stay away from that. I think there's more risk infection when you put a central line, but certainly it can be done if you need it for those who have really tough veins or hard to get access for. I got one. Yes. So what we've done more recently is just advise the patient, drink more liquids, get them more hydrated. We keep trying without that, but if we need it, you need it. So. Leukapheresis, I mentioned that term, it can take 2 to 4 hours. Some patients have told me maybe a little bit longer. Because the needle, it's important to have you stay still. It does take a little bit of time, but also they do have a nice chair for you, but some patients report instead of getting up, they have a sort of urinal system. But instead of using that, sometimes they just say, wear the pants, and they, if they have to urinate, they just go while they're there. It's not the best description for that. We certainly don't want to advertise that, but certainly want to make sure you know that what you're getting into if that happens. But again, that's if you counsel them ahead of time is what we found. Let them know about that. They certainly go before they even get hooked up, and most patients are fine. Some fatigue, chills, slight tiring, hands, tingling of hands and feet, maybe around your mouth. Some studies show a little bit of hypocalcemia, a little bit drop in your calcium can occur sometimes. I haven't seen that from my patients, but that has been reported. The IV infusion takes place at your healthcare provider's office. We do pre-medicate, as the slide shows, some Tylenol over the counter you can take, or antihistamine prior to coming in. And then it takes about an hour to infuse the patients, and then we always monitor them for about half an hour just to be on the safe side. I mentioned sort of the three by three, 6 total appointments. There can be a little flexibility, as I mentioned, an interval when you start, depending on the day that you get. It's a very, very advanced and very actual incredible system when you think about it. When they go send your white cells to that lab, they manufacture pretty quick turnaround when you think about it scientifically, and then they literally fly it to that center wherever you're at in the nation. And they do a great job to get transportation, whatever it takes to get you there. So is it right for you? There's various sort of, several men standing there in front of you. In a nutshell, though, there's just different ways to sort of get to the endpoint. Again, the endpoint is essentially, as I mentioned, this MCRPC. So there's various ways to get there. There's some men, for example, that present de novo, they call it, sort of they show up in your center, their PSA was high, they do a biopsy, if they have cancer, they do imaging because it was so high, PSA was so high, and they're metastatic already, so they call that metastatic hormone sensitive. Other patients have had surgery or radiation, as we mentioned, have PSA rising, get on hormones, become castrate-resistant, and then they do imaging and then find out they're metastatic. So two major sort of side by side sort of pathways, and so that's sort of describing various situations and how to get there. But at the end of the day, you have to be at this time, castrate-resistant and metastatic to be indicated, to qualify, I should say. Oh, I could press this the whole time. Okay, good. So are you eligible for Provenge? As I mentioned, the metastatic, castrate-resistant. So again, castrate-resistant means your testosterone is low, but the PSA is still rising. You do have imaging confirming your metastases. One thing I haven't mentioned is at the very bottom, narcotics for cancer-related pain. Because the trial enrolled patients who are not on narcotics for cancer pain, of course, then the FDA and the guidelines say you should not be enrolling patients for that reason, meaning if you have reliance on narcotics for cancer pain. Now, if they're taking narcotics for arthritis and other things, not cancer, then certainly that's okay. So check with your doctor to see if you meet the criteria. There's an enrollment form you fill out. Your doctor staff will help you with that. Verify your insurance, of course, very important. They'll schedule the days for you and try to stick with those days. Those days are a little bit set because, as you saw, it's a little process to make sure it's done in a timely fashion. Coverage, you or your partner can call the insurance company, determine the financial responsibilities up front, contact your doctor's office, of course, but the insurance company really these days dictate a lot of the terms, I should say, how the coverage is. Patient assistance is available. Patient Access Network, many of you may be familiar with. There's a lot of third-party groups like that have funding. That one in particular, you have to sometimes get up at 7 a.m. It's like winning the lottery. You have to keep pressing on the computer to try to enroll patients in it to get funding. So we have staff to help that. I don't know if some offices may not, but we really try to do our best for that, get funding as much as we can for patients. Empowering you to take action, a few sort of general concepts. Again, Tom, I think, will do a better job than I will. But certainly communicate with your doctor. Talk about your past medical history, past surgical history. Have an open communication. Really understand what you're getting into. Have a treatment plan outline. Certainly keep track of your PSA. Many of you probably do that. Scans as well. And treatment, again, the take-home is the treatment earlier is better, at least with Provenge, and generally true for most situations, most therapies as well. Have a positive attitude, though. Support group. Talk to other patients, and so I think what we're doing today is wonderful. I can't emphasize that enough. I think we see that is a lot of our breast cancer patients, they have tons of support through American Cancer Society. And I was a little bit shocked when I asked them for funding for our prostate cancer members and survivors. They essentially told me they had none. So it was quite interesting. So certainly these seminars and these sort of gatherings are very informative, but also supportive as well. Educate yourself. Certainly these days online is very easy to access. Certainly be careful what you read online, though. It's not always as advertised. Patient responsibility in general, as we mentioned, keep track of your medications, know what medications worked before, what didn't, any allergies, and of course, keep track of your insurance. If it changes, let the doctor's office know. Get the most out of your appointments. Certainly have an extra ear, your partner with you to listen, take notes. Follow up on your test results. Yeah, that's interesting. On the follow-up test results, I hear that a lot. The patients say no one ever calls them. Luckily, it's about the other doctors, but we always track their results. So even if it's normal, we make an effort to let the patients know. But oftentimes, some offices take a while, if ever, to let you know if it's normal, which isn't the best way to do it, but it can happen. So community support is important, as we've mentioned, coming here today. And there we go. Then we have a message from our ambassador, Tom.
Thank you, Dr. John.
Yes.
Can you all hear me okay? This mic's good? Good. I'm so glad to be here. Thank you for letting me be here today. My name is Tom McKenzie, and before I was diagnosed with cancer, I thought I was Superman. Now, I'm guessing that a few of you out here had that same illusion I did before you were diagnosed with prostate cancer. And I'm going to get into that in just a minute. But first, let me just tell you a little bit about myself. First of all, my wife Debbie and my wife Debbie is right over here. She is a saint, and you may get that impression as I continue to speak. But we met in college. We've been married now for 47 years. We'll celebrate our 48th year a little later this year. We have two wonderful children, a son over on the right-hand side, my son and his family, my daughter and her family on the left-hand side there. That young couple in the middle, of course, is Tom and Debbie. And you may remember, now I've pointed this out before. Yes, that is a white leisure suit I'm wearing. Now, those of you that remember the early to mid-'70s may remember that form of attire. And I was a product of the 70s. I was actually a product of the 60s as well. But you know what they say about the 60s, don't you? If you can remember the 60s, you weren't there. That's right. So anyways, my family is just a wonderful part of my life and has been certainly a real important part of my healing and my therapy. So I wanted to point that out to you. Now, I worked in the pharmaceutical industry for 27 years, left the pharmaceutical industry and went into the data privacy and security world. And that, you talk about jumping from the frying pan to the fire. But I was in the data privacy and security world for 15 years before retiring in mid-2020. So I've been retired just a couple of years now. I always like to say that Dendreon, the company that is the Provenge manufacturers, they're sponsoring me today. They're paying me to speak for you. But that certainly is not why I'm here. And I want to be real clear about that. I'm here because I really think that my journey and which may not be all that different than what many of you are going through, but my journey, the perspective I have, the experiences that I've had, I think that some of those may help provide some comfort, some confidence, and in some respects, some hope to people like you that are in various stages of your journey. That's why I'm here. Okay, so let's get back to that Superman thing for a second. So I was one of those guys that has always been healthy. I grew up actually here in Southern California. I don't live here anymore, but I grew up in Southern California. I was a multi-sport athlete. I spent the summer surfing up and down the coast. I spent the winters skiing up at Mount Baldy, if those of you are familiar or skiers and know where Mount Baldy is. I played football at the University of Colorado, and I've always been in really pretty good shape. If I gained a little bit of weight, I never had any trouble losing that weight. I will tell you that ability for me to lose weight is something that my wife Debbie has said it's just injustice. You know, I shouldn't have that ability to lose weight like that, but it is what it is. And I will say on those rare occasions when I would go to a doctor or have blood work done, my numbers were always great. You know, they were exactly what they should have been. All of these Superman qualities kind of led me to having an understanding with doctors. And that is to say, if I could get up in the morning, get out of bed, I probably didn't need a doctor. And that's the way I lived my life until about 7 years ago when I was diagnosed with advanced prostate cancer. So let me tell you about that little journey. So I began having what to me felt like back pain, lower back pain. And after I'm seeing some nodding, so I'm guessing that that's maybe symptoms that some of you were familiar with. At some point in time, I realized that it wasn't back pain. It was too low for even back pain. It was really on my pelvic floor. And I thought, I've got prostatitis. So I scheduled myself for an annual physical. Well, it wasn't really annual because you see, I hadn't had a physical in 16 years. It had been a while. You think that's a little too much time in between physicals? Yeah, I'd say it was. So I scheduled an annual physical or a physical. And I'd be honest with you, I didn't even have a family practice physician at that time. I had a group that I kind of would go to when that really was called for. But, you know, the doctors that I had seen over the years, most of those guys had retired. And so I didn't really even have a doctor of record. I'm sure if you called that group and asked them about Tom McKenzie, they would say, Tom who? I just never went. So I got hooked up with an internal medicine physician who actually is now my primary doctor. And I went and saw him for my physical. And, you know, they did all the poking and the prodding and the listening and the blood work and this and that. And we're sitting in his office and he's going down the list of blood work. And everything was great. Superman, right? Everything was just perfect. All of a sudden, he stops cold. And he's just looking at his computer screen. And he says, this can't be right. We need to have this retested. It says your PSA is 143. So he retested it. What do you think my PSA was? Well, it was still 143. At that point, the guy in the cape and tights knew he had a battle in front of him. And I think, as you can imagine, things started moving pretty quickly after that. I got scheduled for a biopsy right away, although I'll tell you, with a PSA of 143, there really isn't a whole lot more you need to know. That's pretty much diagnostic. But they went through the process like they should of doing the biopsy. I had scans, I had a CT scan, I had an MRI, I had bone scans. The results of all of that stuff showed that not only was my prostate a mess, as you can imagine, I had involvement in pelvic lymph nodes, my seminal vessels, the outer surface of my bladder was showing some involvement, and I had a spot on a rib on my left-hand side here. So we knew we had a lot going on at that point. You know, but looking back, I think, was I freaked out about it? And I really wasn't. And I don't know if it was just a Superman thing or what it was, but I wasn't all that freaked out. I just knew that we would probably battle this like we've battled everything else. I'll tell you that the urologist that did my biopsy was not as positive. In fact, he took Debbie aside the evening of my biopsy, and he gave her a very dire prognosis. Pretty much told her that we needed to get my things in order. So that's where he was at. I mean, he was talking way, as far as I'm concerned, way at the end of the fight before I had even thrown my first punch. And I'm a fighter. So anyways, that was something, you know. And another thing I learned that night is our wives and our caregivers. Cancer is a tough diagnosis for a man to receive, prostate cancer, any cancer for that matter. But it's just as tough on our wives, and that was something I learned that night when this guy was giving her that very dire prognosis. And I've tried to be real sensitive about that over time, because I really think that's important. But in January, and by the way, this was all the beginning of January of 2016. A little later that month, I got hooked up with a really great oncologist at a wonderful cancer center in North Carolina, Durham, North Carolina. I'm being treated at Duke is where I'm being treated. And this guy was wonderful. One of my early visits, he came in the room. He's got this big smile on his face. He always has a big smile on his face. He comes into the room and he sits down and he says, "Tom, I want you to know that there are a lot of tools in the toolbox for treating prostate cancer. And there's not a single one that we can't use on you." And I want to tell you that statement to me, that there are a lot of tools in the toolbox, has really become a mantra for me. I mean, it's important that we all, as patients, know there are a lot of tools in the toolbox. And it's something that you'll hear me talk about often when I'm talking to people. I talk about the tools in the toolbox. And so let me talk about the first one I had. I had ADT therapy right out of the gate. Now, that's pretty much standard of care. And I saw earlier on, there were a lot of hands raised when it was asked who's on ADT. So I think most of you are probably on ADT. And that's not an easy thing to go through. I mean, you know, there are a lot of side effects associated with ADT therapy. Some of them are very personal between a man and his spouse or a significant other. But so there's a lot of side effects that are just nagging. Hot flashes, for instance. How many of you have had hot flashes with your ADT? Yeah, that's not uncommon. I'll tell you, the first time I had a hot flash, a real good hot flash, Debbie and I were watching TV. And this hot flash came over me, and I thought, I said, "Debbie, I'm having this huge hot flash. I mean, the back of my neck was all wet, and my lovely wife looks at me, and she just kind of tilts her head and smiles and says, "Welcome to my world." I guess I got a little dose of empathy that night. I'll tell you what else I learned that night. Don't complain about your hot flashes to your wife. So I'm a quick learner. I'll tell you that for sure. But yeah, ADT therapy, I thought that was a heck of a thing to do to Superman. But, you know, you do what you got to do, and you fight the fight. Now, because of the stage of cancer that I had and my PSA and where we were at, the second tool out of the toolbox for me was actually chemotherapy. And I can tell you a lot of stories about chemotherapy. We don't even have time for me to tell you all the stories I've got on chemotherapy. First of all, I call that my lost year. And there's a lot of that brain fog that you get with chemotherapy, and that's a very real thing. There's one other story I'll tell you. The first time I went in for my first chemotherapy type of appointment, I'm sitting in the infusion center in the chair, reclined, and their nurse comes in, and she's got a gown on and sets this box up on the counter, and it's, you know, certainly got my chemotherapy bag in there. She proceeds to put on a pair of gloves. She immediately proceeds to put on a second pair of gloves. And I looked at her and I said, "Couldn't help but notice you put on 2 pairs of gloves. Why is that?" And she says, "Well, this stuff is really toxic, so we have to be careful how we handle it." Yeah. And I looked at her and I kind of pointed at the box and I kind of pointed at my arm, and we had a little bit of an awkward moment there. But I broke that moment with a big smile because I didn't want her to feel uncomfortable. I knew that stuff was toxic. And they do deal with it every day, all day. And so I understood. But it's, I'll tell you what, chemotherapy and this, you know, this is probably not a surprise to you. It's not for sissies. It's tough stuff. And I'd be happy to answer any questions you might have about chemotherapy after we're finished here. But the chemotherapy really worked quite well for me. In fact, for about 18 months, my PSAs were staying very, very low, but then they started to rise again. And I'd go in and you know, it'd be up a point, or it'd be up 1.5 points, it'd be up 2 points. And after the course of about 3 visits, it was very clear that a trend was starting to go on. It was still pretty low, relatively speaking, with certainly no 143, but it had gotten to about 5. And my oncologist actually recommended that the next tool out of the toolbox be Provenge. Now, you've heard the doctor talk about Provenge, and so I'm not gonna go over a lot of that same ground that he went over, but I do want to tell you that in discussions with my team, the whole aspect of Provenge seemed to make a lot of sense to me. First of all, it's a personalized immunotherapy. That makes sense to me. The fact that it's an immunotherapy made sense to me at the time because I had done a lot of reading about immunotherapies being used in cancer treatment and that was kind of the new thing. And so it was nice that we were doing that. The fact that it was a personalized immunotherapy was even better. It used my own immune cells to ramp up my immune system to find and attack my prostate cancer. I mean, that's a personal approach that certainly made sense to me. We talked through some of the side effects that could come about with using it, and Dr. Hsiang talked about that as well. So I'm not going to get too deep into that. It worked into my way of life. You know, it was a simple therapy to go through. It took about a month to go through all of it. So it certainly was not a big deal for me to go through at all. It's 3 cycles. Like I say, it takes about a month, maybe 6 weeks. I will go through the 2 steps of it. The 2 steps, one is the cell collection step. That's the leukapheresis step. So I had my leukapheresis done at a Red Cross, and they got me in there, and they had both arms. I had a line in my left arm, and blood was coming out of the left arm, and it was going through a machine. The machine, if you've ever had platelets taken out, you probably have seen these machines. You know, it's spinning and clicking and doing all sorts of stuff, and then they got another line coming out over on this side going into my right arm, and that's where the stuff it didn't take out is being returned back to me there. And it just seemed like kind of I don't know. I half expected Dr. Frankenstein to kind of step out from behind a screen someplace and address me, but that's just kind of the way it goes. I had to lay very still because, as the doctor mentioned, the needles are those stiffer needles. They're not those nice little flexible needles that you might get when you're doing chemotherapy, but they are stiff needles, so they want you lying very still. If you get an itch on your nose, and by the way, when you're laying like that, you're going to get an itch on your nose. Happens every time. So you have to have a nurse come and scratch your nose to get all that done. But then you've got so once the cells are extracted, they send it off to the manufacturing facility where it's mixed with the things that the doctor talked about. You know, I'm not a scientist. I call it their magic. And they supercharge those immune cells, and then they send it back to the infusion center for it to be infused. All of this takes place in just a matter of a couple of days, which is incredible to me. The center that mine were sent to was in Atlanta, Georgia. I know there are other centers around the country. Mine was in Atlanta. But I will tell you one story when that was sent back in my first infusion. Debbie actually was with me, and we were standing in the lobby of the cancer center, and an overnight delivery guy comes through the door, and he puts a box up on the counter, says this goes to the 4th floor. I could see on the box that it was from Dendreon, and Debbie and I looked at each other, and we knew that my dose of Provenge was in that box, and they were taking it up and going to get it ready to infuse in me. And just the whole thought process of what went behind the scenes in just these last couple of days, literally couple of days, to get that thing to my cancer center for the infusion was a little overwhelming. In fact, Debbie teared up when we thought about it. And Superman got a little bit misty too, but he was able to hold it together. But it is an incredible process, I'll tell you that. I will tell you that I'm happy to say the therapy was easy to tolerate. During or after the leukapheresis, I would go home and I would have tremendous fatigue, and I'd have to take a nap on that day. And I'm not a napper, so that's unusual for me. But by the next day, I was fine and really doing kind of whatever activities I would normally do. Other than that, I mean, I had some joint pain that they say you can have. I had some of that. I know there's some other stuff, some fever, some back pain, some nausea you can have, headaches. Some people get headaches. I didn't have any of that. I tolerated it really pretty well. But I'm pleased to tell you that it was over 5 years ago that I had Provenge. You know, I look at those numbers that the doctor's putting up there and I think, yeah, you know, I mean, clinical studies are one thing, real life is another, and my real life is I'm still going strong, and it was over 5 years ago I took Provenge. Now, I will tell you that I've had some ups and downs on my journey since then. I'm going to be honest with you. Provenge is not a cure. It is a treatment. It's an important treatment, but it's a treatment. I have had tweaks to my ADT therapy, multiple tweaks to my ADT therapy. I was involved in a clinical study for an investigational drug. I've had 2 rounds of radiation, both of which were very targeted radiation, SBRT. I can't remember what the actual name of, I know the acronyms, but the full names I don't have quite as well. The SBRT is real localized. It's multiple beams, very high dose, multiple beams all converging at one location. Reminds me of the Ghostbusters. You remember in Ghostbusters when they said, don't cross the beams? You remember that? Well, in this case, you want to cross the beams, but you want to cross them right at the cancer. So I had that. Currently, my prostate cancer is in very good control, knock on wood. As of 4 weeks ago, my last visit, my PSA is 0.04. So that also is a long way away from 143. So I'm actually doing quite well. I can tell you, and there's my beautiful bride. You know, she's a little older there than that last picture, but she still is beautiful, isn't she? So I'm an avid golfer, and I play 2 to 3 days a week. I shoot competitive skeet during the summertime. I play the guitar and drums. I won't tell you which instrument I prefer, but I will tell you that Debbie has a t-shirt that says, I'm with the drummer. I'm going to leave you with just a few final thoughts that I have, and then we can answer questions or whatever we have time for. First of all, don't let cancer take over your life. That's really important. Cancer is what you have. It is not who you are. And there is too much joy to be had in this life for you to allow cancer to really take it over. Don't let it happen. Don't let cancer take over your life. Advocate for yourself. And that means a lot of different things. First of all, it means ask questions. And I have the feeling this group asks lots of questions of their healthcare professionals. Ask questions. Make sure you understand the disease that you have. Make sure you understand the tools in the toolbox. You know, what is available to you to be treated. Really important. The Provenge website's actually a good place to start, but there's lots of resources where you can gain information on that. And as you all know for sure, you're not on this journey alone, so you know, don't think you are. I always also recommend including a mind-body-spirit approach to your treatment. Now, for me, it's a daily practice of meditation. And I've been doing that for a number of years. It's become a very important part of my life. But find ways to inject a mind-body type of approach. Your mind and body are inextricably linked. And there's all this communication that's going back and forth between your mind and body all the time. And you can control an awful lot of things that will help your immune system, reduce your stress, those types of things. Find a way to include a mind-body approach to your treatment. Keep a sense of humor. My brother used to say it's a long day without a laugh. And I believe that to be true as well. A sense of humor is critical. I found a sense of humor was great even with my friends, because when they knew I had the stage of cancer that I had, a lot of them didn't even know what to say to me, you know, and it was like they wouldn't say anything, or I wouldn't hear from them, you know, those types of things. And when they saw I could crack jokes about my treatment and my disease, not that it's a joking matter, it's not. It's a serious disease, but you got to keep your sense of humor. Good things happen in your body when you laugh. I mean, science has proven that. So you need to find a way to laugh every day. Don't go through a day without it. And then I guess finally I'll just leave you with that thought that I started with, and that is there's a lot of tools in the toolbox. So hang in there and fight the fight. You can do it. Thank you all very much.
I'd like to thank both Dr. Hsiang and Mr. McKenzie for speaking to us today. Let's just take a few minutes for some questions that anyone has, and then we're going to break for lunch. And a little secret today is that Dendreon has catered our lunch today, so you're in for quite a treat from Urban Plates. So why don't you come on up, Doctor? And anyone have any questions?
Good morning. Thank you for being here today. I have a two-part question. First part is, does Provenge help with hormone-sensitive prostate cancer? And the second part, is there some kind of a screening available for avoiding the severe side effects?
So the short answer is no to the first one. Unfortunately, as I kept emphasizing, metastatic castrate resistance is the FDA approval at this time. I'm hopeful it can be moved earlier as in hormone-sensitive patients, but we don't have the trials yet to show that.
Thank you.
And then what was your other one you said, your other part? Oh, okay.
Now, as I understand it, this system works by taking T cells from your bloodstream and exposing them to a protein that's supposed to be that's a marker for prostate cancer cells, and then sends the modified T cells back. That sounds a lot like a vaccine approach. Is there any way or thought of converting this system into a real vaccine where you inject, say, an mRNA into your bloodstream and tell the T cells about it that way?
Yeah, I would not know. I cannot comment on that. We have to be through Dendreon. But I'm hopeful. Yes, what you said is totally true. Right. I think with all the COVID mRNA, the sort of boom in our knowledge base in that, I think that could be the new trend. But again, I can't say on behalf of Dendreon. But I suspect that someone's looking at that for sure.
I know this is no dumb questions, only smart answers, but I've got to ask this question. 1 out of 7 men are going to contract prostate cancer. It could not have been that way 50, 75, or even 100 years ago. What on earth is causing either the food we ingest, the air we breathe, or whatever to get to the point where it finds that spot of all places to land, as opposed to in your nose or your ears or whatever? What is the root cause of prostate cancer? Is anybody working on that or have an idea where that is?
You would win the Nobel Peace Prize if you could tell me that. That's the short answer. But no, in all seriousness, it'll fluctuate. The new diagnosis incidence, they call it. And even since many years ago in my training, it's always hovered around that, as well as breast cancer. I've seen numbers 1 in 7, 1 in 8, 1 in 9. It's been holding relatively steadily. Some of that, though, keep in mind, is not as straightforward. Certainly, is biology is part of that, that we don't understand the cause, meaning. But certainly, some of that could be artificial. There's a lot of debate about over-screening, not just prostate, but even breast cancer. And then what are we doing with that? Are we over-treating that? And so there's a discussion of the significance of when you find it. How significant is it? But the incidence itself depends on how much we look for it, right? How often does the urologist do that biopsy? At what point does he do that biopsy? We had similar numbers many years ago of metastatic patients, but what we've seen in the past few years is a surge of metastatic patients walking into our offices because some of you might know the U.S. task force, for example, sort of got rid of PSA screening completely. They said, no, you don't need it at all. And that was many years ago. And then a few years later, we saw a huge spike in the metastatic patients I'm talking about. And I'm on the front lines, and I'm shaking my head going, what are we doing here? So it took a few years because prostate cancer patients, or men in general, don't really argue. So we just said, put our heads down and said, okay, fine, we don't need screening. And that's where patients were getting metastatic disease, not even diagnosed. We've since reversed some of that. Now the official recommendation is, talk to your physician. And so a lot of PCPs are starting to screen a little bit more, but there's still a lot of debate on that. So those are things that can affect your risk as well. Yes. Go ahead.
So Provenge is a single course of treatment, just the 6 visits and you're done, and there's never any a second treatment that you may need to go through.
Yes, I've always also wondered about that. So in theory, I think there certainly can be a role, but again, that'll be up to Dendreon to answer. I'm sure they're looking at that. One thing related to that I can say is they've looked at those trials, and that sort of immune activation continues for a while. Some of the, not just T cells, but they call the B cells come in afterwards. And for example, if the cells that get killed, all that sort of debris, your B cells, antibodies form, and those can be around for a long time. So, so who knows? Maybe we don't need to really add any more. But again, that's research to be.
I have a couple more too.
Yeah.
So you mentioned that the treatment Provenge does not lower PSA. So how do you know if it's working?
Well, yes, you have to have a little bit of faith, is what I tell my patients. But no, not just faith, of course. I point to some of these trials, of course. The trials certainly prove that it works over time. But that's my other phrase, only time will tell. And so I can't prove it to you, especially as an individual patient. But I can tell you, in a randomized study, in a patient who did not have it certainly lived less months, had less months of survival. So the proof is there in the data, but yeah, it is hard to show you as a patient.
Yeah, I have a question for Tom. You said you had one metastasis that was up in your rib cage.
Yes.
So after the treatment with Provenge, what are the scans shown? Is it still metastasizing more, or is it stable?
No, actually, the spot on my rib is completely gone. I still have regional involvement, but it is considerably less. And that's when we brought in the radiation treatment, was to start to get some of those more regional things. The lymph node, I had a right pelvic lymph node that was the primary one that was involved, and it was quite enlarged. And so we zapped that one pretty good. And then I had a scan, PSMA. Are you familiar with the PSMA? The PET scans, which are relatively new, highly sensitive for finding prostate cancer cells. And it confirmed that I didn't have anything on my rib anymore. And my cancer is now really pretty much confined to the prostate, with still a little bit of regional involvement, but it's much less. But after I had that scan, that's when my oncologist said, let's go after this thing, and let's really go after it in the prostate. And we gave it a good shot in the prostate as well. And that was the last radiation that I had was on the prostate itself. So kind of a long answer to a short question, but.
All right, and our last question for today.
My journey is very similar to Tom's, and which is to say that my cancer was metastatic at diagnosis. So I was curious how long from when you began hormone suppression and the chemo until your PSA started inching back up again. What was the kind of the time frame for that? And then for the doctors, wanted to ask, are there studies running right now to see about using Provenge before castration resistance?
Yeah, that's a good question. I did respond pretty quickly to the androgen deprivation therapy, and my PSA started coming down precipitously. But just because it was in other sites and the bone and that type of thing, that's why we decided to go with the chemotherapy pretty quickly. I mean, I was diagnosed in like mid-January 2016. I was on chemotherapy by the end of January of 2016. So we jumped right to that, even though we probably didn't even see the full results of what the ADT could have done just on its own. Yeah, it was about 18 months after my chemotherapy. Yeah, it had gone down very, very low, and then it started inching up. My PSA when I went on to Provenge was about 5.
All right, we need to break for lunch now, but thanks again to all of our speakers today. There's also, in the packets, in the bags from Dendrian, there is a feedback form. Please fill that out before you leave and provide it back to Shelley over here. They would certainly appreciate the feedback. And again, thank you all for attending.